Hello and welcome everybody to the Contura Vet event, long-term use of 2.5% iPAAG in performance horses. My name is Robin and I will be your VetPD host. First, I would like to thank our group of panelists and our moderator who are experts in the field. Thank you for your willingness to be a part of this event. And then I would like to thank Contura for allowing VetPD to also be a part of this and organize this event. I would also like to welcome and introduce Dr. Megan Green, who is the veterinary technical specialist. And I'm going to hand it over to her. She will be the moderator for the event.
Thank you, Robin.
Welcome.
Thank you to everyone who has chosen or taken the opportunity out of your busy schedules to come and join us for this webinar with the VetPD. We're so honored to have them and our panelists tonight. And I'd like to take a moment to introduce our panelists, starting with Dr. Jason Lowe, who is the Contura Chief Veterinary Global Officer, as well as one of the co-authors on multiple research papers, as well as Dr. J.D. Conway, who is our Director of Veterinary Services for Contura Vet, and then also Dr. Leigh de Clifford, who is a partner at Matter Vet Services and also a researcher and co-author along with Dr. Lowe. So without further ado, I'm going to turn it over to Dr. Lowe.
Great. Thank you, Meg. And you got some slides there, JD, you were going to put up.
Yeah, I'll go ahead and share my screen here.
I think the big thing really where I sort of, while you're just doing that, was to, I guess, start off by talking about the molecule, because to me, going around the world now, I guess, and talking to veterinarians and things, it's when you really start to understand the 2.5 injectable polyacrylamide molecule, you really start to understand and appreciate just what it's doing in the joint. And it's got a pretty long history of development. It's been over 20 years now that Contura has been working with the 2.5%. And it's what we know is that 2.5% just seems to be the right concentration of this hydrogel to be the most biocompatible with tissue, with human tissue and animal tissue. And it started off its sort of history actually in human medicine, where it was used for facial augmentation, really in cosmetic surgery, and contouring body parts, which is actually where the name Contura came from, sort of a substitute for hyaluronic acid. But then over the years, it then started getting used in animal joints, and that was really because it seemed to mimic hyaluronic acid. So literally somebody thought, wow, they use hyaluronic acid in joints. Let's try some of this 2.5 iPAAG in a joint, and it worked. And then sort of the early 2000s, some of the research papers came through, the goat study was done. That's when Leigh and I sort of picked up the product too, crikey, almost 10 years ago now. And then things have just gone from there, right? As we've done more research, it's moved back into human medicine now for intra-articular use, and we've sort of got to where we are today. And I think it's that unique biocompatibility, the unique chemistry, viscoelastic properties of the gel that just really make it quite special. And I guess that's the purpose of today, right? Just to have those conversations and talk about it. So if you've got any comments on that, Meg, or questions?
Yes. So one of the things I think that's interesting when you look at this timeline, and particularly, you see that we start with end stage OA focus studies. And so I just would really like to kind of get your thoughts as a panel, and each of, what your thoughts are is like, why, as veterinarians, do we always start with end stage disease with these new products and expect them to be miracle workers?
Yeah, that's a great question. And I think I've just been up in Europe actually and talking to some of the original veterinarians that got involved way back then. And of course, it was the risk profile, right? They started putting it into horses that had failed every other treatment. These were horses that were literally going to be put down because they were chronically lame. And it was hey, shall we try this? We've got nothing to lose and see what happens. And it worked in 80% of those horses. And I think the original horse was literally, again, was going to be fully retired. They put it in, it ended up going back to racing, and I think that's when the veterinarians got excited about it. So I guess I get that start, and to be fair, it's probably where Leigh and I started as well, was sort of cases that, because that's when we picked up the product, and it was cases that we tried everything else on that we had no chance. But in probably 5 or 6 years of working with the product, we completely changed our mindset and started using it in cases earlier and earlier. And now I think we pretty much start with arthrimid when we get a lame horse. I don't know if you want to comment to that, Leigh. Just on mute there.
You're on mute, Leigh.
Yes, sorry about that. Yeah, no, it's an interesting concept because obviously we often don't see the animal until there's clear lameness present in terms of performance limiting lameness. But often an inflamed joint is ticking away for a lot longer than what you realize. And so you only see things when they pop up and when the client actually wants you to look at it as well. And a lot of financial constraints around us looking at them early versus late. And that alters when we see cases.
Yeah, but it sort of makes sense, doesn't it, to treat it earlier? I always look at OA as it's a degenerative disease. We know it gets worse with age, and if we can treat it early, then we do seem to get better responses right before you've got those chronic changes in the joint. But I agree with
Yeah,
what you're
definitely.
saying.
And it's yeah, and you just move and you educate your client that you almost get that first one-off win with them, and then they go, oh, okay, and then you have the conversation. Let's get in early. Let's monitor these things. And it's the same with all disciplines, whether it be racing, Western, dressage, show jumping. That you just educate the clients, and over time, when they talk to each other at the bar or at shows, etc., they'll start spreading the word themselves, and it's a two-way street. You just got to get that education out. That the sooner you get in there, the better the results. And that's sort of how I think it's morphed over time. And I found that the earlier you get in, the lower dose rate you can use as well.
So
Yeah.
speaking of that and like the changes and as far as treatment modalities and things like that, one of the things that we get asked a lot is, the approach and thinking about conventional therapies versus starting to consider utilizing a polyacrylamide. And one of the big things as far as a game changer in clinical practice, specifically for me, was looking at the double-blinded study that you all did in comparison with triamcinolone and HA, and comparing that to Arthromed and seeing those horses and what those effects were, and looking at the outcomes of that particular study. And so I would really appreciate the opportunity to kind of see how that's changed, how you manage those cases based on that particular study, and what your sort of thoughts are as far as how you're utilizing HA and triamcinolone today comparatively to back then.
Yeah, I think again, it's a good question. It's because we've done our pilot study sort of before that, the pivotal study, the double-blinded was our pivotal study that we used to get market authorization in Australia and New Zealand. But through the pilot study, which was published in 2019, I think we started to get a much better idea about the type of cases it was working best in, as Leigh said, earlier intervention. And it's probably, I guess in hindsight, it's a product like this now allows us to treat early in the disease, because before we were always behind the 8 ball, and we were, when you just had like the cortisone, you were always sort of holding off as long as you could before you use something. But I think then in the pivotal study, it really highlighted to us, and again, Leigh, you'll comment, but an early stage naturally occurring disease, which is what we see in racing horses, right? And that they're 2 and 3-year-old young horses that have come into high speed work at a pretty young age, and they go sore real quick with synovitis and capsulitis. And I think that's where it starts. And I think as veterinarians, we're much better at identifying some of the developmental orthopedic diseases and sort of sorting those out before they become problematic. Yeah, there's conformation issues and stuff, but it's that repetitive load under high speed that we're trying to manage in these horses. And so I think that's where we just started going, this is a product that allows us to target that stage of the disease effectively early on. And that's, we just started doing it more and more, wasn't it, Leigh? And I think that's also, as you said, we've started to educate the trainers and the owners around that sort of thing as well.
Yeah, certainly in that study, I think it was 80% of the individuals enrolled had no radiological changes present, which is, I think, very indicative of the population, as Jason was saying, at that level. And, and again, an inflamed synovium, which is for a bulk of joint lameness, that's the key driver for all future problems. And obviously, there are other things that can cause the joint lameness, but the inflamed synovium is the number one, and you're not going to see it on an X-ray. So that's why we started doing that, and it's just over time too. If you start off with something that's really bad, and you go, "Geez, that worked pretty well. Let's actually move it down the spectrum and get it early on." And then once you start getting into your results, it just starts rolling from there. And again, I do things a bit differently. So I've found that the earlier you get it, the less radiological changes that are present, the lower dose you can use as well. And I think you're better off to chip away and do repeat doses over the course of the horse's athletic career at shorter intervals than just doing a larger dose once off every now and again.
And I think that, Leigh, that really leads us to sort of the next thing that I think we should bring up and talk about is some exciting research that you and Jason have done most recently, and looking at a retrospective study over 8 years, because one of the things that often comes up is, talking about redosing of arthromed and the safety of that. And so it really was an opportunity for us to dive back into the research, from clinical cases, to be able to explore, what had been done. And so I think it's an exciting time for us to be able to share this data, and I'd welcome the opportunity for you all to cover that, and we'll give some more discussion questions in a little bit.
Yeah, so obviously that at this point, tens of thousands of doses of the product had been used, and you don't certainly get to that level without there being confidence in the safety of the product. But at this point, up until recently, there was no actual data to back up that theory. So yeah, we spoke to a clinic just out of Melbourne in Australia there that had been using the product for about 10 years now as well, and they've really got their head around the product, how it works, how to manage these horses. Their trainers were fully involved in the product and appreciated what they can achieve by using it. So we approached them, and yeah, they were more than happy to trawl back through their data, through their charging, and find us 703 horses over 8 years that had only had arthromed injected for at least 12 weeks before. So there's up to 12 weeks before the first arthromed, there was nothing else injected at that time. Now, some horses before that had the odd, triamcinolone or IRAP injection, etc. But from 12 weeks before they were enrolled, well, not enrolled, but had the first arthromed injection, they had nothing else following that apart from the odd routine phenylbutazone, meloxicam injection along the way. But as you've got to be able to do that to manage these athletes. So we looked at the data over that time period, and we've got 703 horses. And interestingly, at that time, there was 3 adverse events, and that was over 17,000 races, which was pretty spectacular. So when you consider that the average catastrophic musculoskeletal injury rates in Australia on grass is around 0.4 to 0.5 per thousand starts. So clearly that's well below the industry standard there, which was really good. So what did come from that is that there was one injury, which was a lateral condylar fracture that occurred 7 weeks after arthromed hadn't been injected into that fetlock. Now, what was interesting was that approximately 30 days after the arthromed was injected, the horse had not responded as well as hoped, and the trainer actually or the owner of the horse went and got another vet to come in because they weren't happy with the response, and that horse had received some triamcinolone, and yeah, a couple of weeks later it developed a condylar fracture. So which sort of highlights how the product does work, and certainly how I manage it, how I manage these individuals. If you're not getting a response, go back and do diagnostics again, or do more advanced imaging, because there's a very high chance, if you're confident with your diagnostic workup, that there's subchondral bone pain present, which increases the risk of catastrophic injury. And
That's
then
really
this highlights
important,
the
isn't
risk
it?
that you get.
Yeah, that it's not masking subchondral bone pain, right? And that's so critical. And I think when you look at the research, as you say, around triamcinolone, where we know that masks, and we know the increased risk within sort of 49 days, isn't it, of racing, if you've had triamcinolone, increased fracture rates. So I think that's
Yeah.
where the trainers and in Australia, New Zealand, we've been using the product for quite some time. It's just a real exciting take-home message, isn't it? That it doesn't mask subchondral bone pain. We're not seeing an increase in catastrophic injury rates. In fact, we're seeing a very clear decrease. And I know when we started off, there was sort of some cynicism and healthy skepticism around the product and how it might be working, but that's where this data is so crucial to lean back into, just to show, well, yes, it's not doing that. So it's great.
Yeah, and what was also interesting to glean out of that information that we got was that it didn't matter the number of injections the horse had. So we had a range of 2 through to 9 injections. Now, really, there's very few horses that had 9. And when I say that was an individual joint, one specific joint, or bilateral joints. In a couple of cases and what we found is that those horses did not have a reduction in number of career starts versus horses that had only a single injection. So we know that it's safe, we know that it's effective long term, and that goes back to the point you raised, is that the trainers that I work closely with, or have at least had several discussions with about the product, is that they know that by using it, they can rest easy at night knowing that they're not going to increase the risk of catastrophic injuries, because it won't. It doesn't affect the subchondral bone, and if it doesn't work, they tip the horse out for a spell or do further diagnostic imaging. So they're comfortable that they're not going to break the horse down, which is provides comfort for everyone.
Yeah, absolutely.
I'll ask the question that I'm sure all the U.S. racetrack practitioners want to know: what's the withdrawal in New Zealand and Australia on Arthromed? That's probably because we know what it is with HISA regulations here, but
So we have a clear ruling that all intra-articular injections have an 8 clear day injection, like withhold period. So, and that's for all biologics. And then there are certain little tweaks if you're starting to use corticosteroids, depending on what joint you're in. But so for Arthromed, it's the mandatory 8 clear days. But realistically, I think you need at least that, if not longer, to let it fully work in. I certainly feel that you start to see the effects around about day 10. And then it improves and gets better over the course of 4 to 6 weeks. And that's certainly what we found in our research, that the lameness grades didn't really start to be affected until the 4-week mark. And but again, I think that does depend on the degree of pathology that you've got within the joint you treated.
Yeah,
So
and it's also interesting, isn't it, how that's changed the trainers' mindsets in this part of the world, where they're treating early in the prep. And because again, we know with cortisone, right, you're trying to actually get it as close to racing as you can, because it's got such a short-term action, which probably increases the risk as well. Whereas with this product, put it in early in the prep, we know we get that long-lasting action, 4, 5, 6 months out of it, even in racing horses. So you can get it in early and manage the horse a whole lot better. And again, with the safety of it.
Yeah, and depending on which joint you're putting it into, it depends on the average length of response. I mean, and bearing in mind all the confounding issues, from the data that we were able to pull out of this long-term study, we averaged 234 days between injections. And that's for the 4 main joints, both into the intercarpals, forefoot locks, hind foot locks, and TMTs. So that pretty much fits with what I've found personally from what I do. But I've got to the point now where I use it as my first line treatment, and then use the occasional small amount of, mostly triamcinolone if required, if you've got a horse that is literally running in 8 days' time, 10 days' time, that you don't have enough time for anything else to get in there and take effect.
So one question that comes up is dose dependency, and knowing, sort of looking at that interval time that you're utilizing. Do you think the duration between injections is influenced by the dose itself, particularly in relation to the severity of disease?
Yeah, hugely. Yep, that's definitely. And
So
so
with
yeah, it's the
a higher
the greater
volume.
the degree of clinical signs. So, lameness, and bearing in mind that's not necessarily just asymmetry, it's just the degree of abnormality in that gait of that horse, the degree of effusion, the degree of reaction to flexion, along with radiological changes as well. They all influence how much I do put in.
But it's interesting that chart, the tables that you've got there, right? You've got mostly fetlock joints treated,
Yep.
and bearing in mind this is, I guess, just for people listening, the 214 horses, we've started out with 703. So these are the horses that have, the 214 are horses that have had repeat doses. Is that
Yep.
right? Yeah.
Yes.
So then most of these repeat doses seem to be into fetlocks, and you've got a vast majority of those have been at the 2 ml dose rate. Is that where you're still advocating the 2 mils in the fetlocks? And again, it's just interesting when you look at the human medicine where they're putting up to 6 mil in a human knee joint, a human stifle, significantly higher
Yeah.
in a less active animal.
Yeah, most definitely. I think, and also in that graph there, I think on the left above where it says front fetlock, hind fetlocks, it probably should say ICJs. So they're pretty much on par with the number of injections as well. I'm not sure why that hasn't gone across there, but yeah, I'd say 2 mils is certainly, from my angle, the go-to volume to start with. But you honestly have to be willing to flex a little bit at times, and also see if you've got to do 2, 3, 4 joints on a horse, and the horse hasn't proven itself yet. It's a financially a bit to stomach, and so sometimes you do say, right, well, I'll do a mil in those joints. The 25% chance, 30% chance, you're going to need that extra 1 mil into these joints, but let's just get the ball rolling and see what we get. And often that is actually enough to reduce inflammation in those joints to see the ability of that horse. And then once that is achieved, then they go, right, okay, go ahead and top it up again, and then we'll keep going with the 2 mil from there.
Yeah, it makes sense. We sort of talked about this up in Europe recently, didn't we, JD? And certainly the vets there. I think a lot of vets, because it comes in a 1 mil syringe, they just started using 1 mil and found that it was still actually effective. But I think there's no doubt that 2 mil's better, and certainly in severe cases and bigger joints, you could maybe consider more as well. But I agree, Leigh. You look at the monetary cost, and if you're comparing apples and oranges with the likes of cortisone, which is still pretty cheap, isn't it? But I think the long-term benefits with this product certainly makes it a good value proposition. And again, we don't seem to get much pushback on that anymore with owners and stuff on pricing, because they recognize just how good it is and how long it lasts.
Yep.
JD, have you got
And
any
again,
thoughts
now
on
we've got,
that?
well, yeah,
Yeah, I would agree. And you're right. When we were in Denmark, it was pretty apparent that it was more of a 2 ml starting dose for a lot of these cases, especially, and they're treating a lot of sport horses. The vets that we mentioned and talked to, we'll see some of that work upcoming with Dr. Cooner's work. But for me, who I still do a few horses here and there, mostly in the Western performance barrel racing and then quarter horse racing, I think I'm, doing 2 mils in a ICJ or our, radiocarpal joint. And maybe a mil here and there if it becomes a price issue, but typically it's not. Like I would agree. I don't find that owners are objecting to it. They start to see the long-term effect. It only takes one owner really to, most of the owners that I work with are trainers. They have multiple, horses in their barn. You get the one horse that works well with Arthur-Med, and you don't have to try to sell it again a second time. They get it, and they get the long-term advocacy of the product and the safety as well. So
Yeah.
kind of agree with both Leigh and Jason's points there.
Yeah.
So one thing that comes up as we talk about dosing and talking about volume is veterinarians often are concerned about the accumulation of Arthromed over time and these repeat dosing, and what the volume might be, and could there be an adverse effect on the synovial lining and the joint long term. And based on this research that you've shared with us tonight, I'd just be interested to kind of get your thoughts. And looking at your redosing rates, are you doing the same amount of volume in these horses that you initially did, or are you finding that you're doing less as a result and being able to manage these joints more effectively once Arthromed is in the joint?
Yeah, I'm interested in Leigh's comments on that to start with, because I've certainly got my thoughts on the repeat dosing. It's interesting in that table, right? You got one horse that's had 15 doses with no detrimental effects. So, and a whole lot of them had 3 or 4 repeat doses. But what's your thoughts, Leigh?
Oh, I certainly find that but I've certainly had no issues with it over the years. And if you look at some of the data that we got out of that's work out of Melbourne, we got it here. So at the end of that study there, 39% of these horses were still actually actively in training. 24% of them were retired for age reasons. 17% of them went off to go breeding. 2% of them were retired out of that entire cohort with joint related issues. And I would say that's pretty good going when you consider the number of joints that were injected and the number of horses. So as we know, arthritis is a degenerative condition, and all we can do at best is really manage it on a long-term basis. And again, these are high-end athletes, so I'd like to follow through those 2%, which we're going to look into shortly, and see how they've gone post racing, whether or not obviously dropping down a grade or two and into more equestrian level pursuits. Can they continue to perform well for the new owners? But yeah, I've got no concern at all about it.
Yeah, I think, and I agree. I think to answer your question, Meg, I think to me there's two sides to that discussion, because one side's the science, right? The chemistry, and again back to that, when you actually understand the molecule. And I get where vets sort of think about this, and they pick up a syringe and it's got this 1 mil of gelatinous hydrogel in it, and I'm going to inject that 15 times into one joint. Why doesn't that build up and cause an issue? But what you got to understand is that only is 97.5% of that syringe is water. There's only 2.5% active in there. The actual amount of active is just slightly smaller than the size of a pinhead, right? So you're injecting, that one horse had 15 pinheads into one joint, right? So it's a tiny amount of product going in. I think the other stuff, and JD, some of the work you've been doing with Bo Whitaker, I know, has looked at sort of where the gel goes when you've injected it intra-articularly, and it's not random. It just doesn't disperse anywhere. It actually goes where there's increased cell turnover. So it's going to the sites of injury and damage. So it goes into there and sorts out those areas. And then if you're having to put more in later on, there's another damaged area, right? So it's going somewhere else. So it's spreading itself around the joint capsule, not joint capsule, the synovial membrane. I think the other thing is when they produce this in the factory, they produce this block, if you like, this 10 kilo block of the gel, and it actually goes through a sieve. So each gel particle is 500 microns. Okay, so you're dealing with all these tiny little microscopic. I mean, you see it on a scanning electron microscope at 10,000 times magnification. It's absolutely tiny, and these tiny little particles are getting engulfed and adsorbed or integrated into the synovial membrane. And when they're in there, they're holding water molecules, they're changing the viscoelastic properties of the synovium. They're restoring that biomechanical function. And so, yeah, you just got to understand this is all microscopic. It's not got this big buildup. And I don't know, again, JD, does that sort of make sense when we talk about
Yeah,
it?
no, I agree. And you mentioned Dr. Whitaker's research that he performed on a case with they created a tendon lesion and a deep flexor tendon, and then injected arthromid in that synovial sheath and to see what happens. And did it randomly just, go one place or the other within the sheath? And that wasn't the case. It actually, like you mentioned, just based on the chemical nature of the acrylamide molecule, polyacrylamide molecule, and the attractiveness to the certain regions, it lines up adjacent to the injured tendon, and so
Yeah.
they saw improvement, and it's probably no different when you start to look at other synovial structures and other joints and things. So I think that's pretty spot on, really.
So I think that's it, isn't it? When you understand the chemistry, the science and the chemistry, and then equate it with the clinical picture, which is what Leigh's beautifully presented here. And I know you've got some data from Europe to show shortly as well. We've got the clinical safety coming through that there's just seems to
Yeah.
be, there's no concern over repeat dosing. So yeah,
No, I think it comes down to, some terminology, and it sort of brings up, this study that you were able to present on at AEP this year, and
yeah,
maybe.
yeah, and I'm glad you brought up that slide because I think that's the other thing I get, Meg, as well, is trying to make people understand that this study, right? So it repeated the Christensen 2016 publication on the histology synovial integration of 2.5% IPAG. They used normal and OA joints from rabbits and horses. In our study, this was part of our safety study for market authorization in Australia and New Zealand. We just used normal equine joints, but it sort of shows this typical foreign body response is how it's described in the scientific literature, right? No different than putting a screw into a stifle or across a fracture gap. You just get it stimulates the body's innate immune system to come into that area to try and heal it. And it's transient. Okay, so these macrophages come in. It's not a fibrosis. It's not a granulomatous reaction. The macrophages literally become frustrated um, out to around 90 days. So they've come in the first couple of weeks. The gel moves through into the subintimal space. It sits there. The body goes, oh, well, actually, this isn't causing any problems. It's mimicking the natural tissue. And that's what we mean by biocompatibility. And then the macrophages, they can't get their cytoplasm around this molecule, right? It's too big. So they literally go, well, it's not causing any harm. I'll go off and become a fibroblast, or my life cycle's gone. I'll go and do something else. And so they just give up. So it's a transient foreign body response, and you just end up with this integrated gel performing its biomechanical support of the synovium, which we know is long term. So I think it just all makes sense to me.
So when you look at this study in particular, thinking about clinical insights and study results, what are your clinical interpretations of the gross pathology and cytology findings from this study?
Again, I think the key to me was it removed the confusion around that gel sits inside the joint, because I've heard surgeons talk about this. I've heard, and I think it comes from the earlier Christensen work where they sort of described that they could see free gel. We never saw that. We never observed that. And when you actually look at it histologically, the 2.5% is fully integrated, fully adsorbed beneath the synovial membrane. And I think what they saw in that earlier study was that the gel is transparent. The intimal layer of the synovium is transparent. So you're looking through the very, very fine cellular layer into this sort of augmented membrane underneath, and they thought it looked like the gel sitting there, but it's not. It's, microscopically, histologically, we've proven that the gel goes out of the joint. So, and it's a good thing, right? You don't actually want a gel sitting around in the joint, because the body is treating it as a foreign body. It's trying to, and that's how the membrane functions, isn't it? It doesn't have a basement membrane between the intima and subintima, so it's constantly pulling particles out of the joint. Just as well, it's the synovial fluid is formed as an ultrafiltrate from the blood. So that's how synovial fluid's being formed with the synovial cells secreting molecules as well, hyaluronic acids and things. Does that sort of make sense? Is the way I answered that?
It does. It does. And it brings me sort of to another question that comes up as well that I'd like your comments on is, histological findings and the clinical implications. Looking at the study and how it describes an increase in cellular infiltration of the macrophages, clinically, how might this be manifested, and what are the best management strategies if this is to occur in one of your cases?
Yeah, well, again, I think Nancy Loving actually gave a great summary of this in equine management recently. When you look at the clinical relevance of this paper, is that, yeah, it is a macrophage-driven response. It never exceeded normal laboratory levels, so it's not an overt response or by definition, it is inflammation, but it's not bad inflammation. It's just part of the body's natural immune response. But if it does, and we do see an incredibly small number, I think globally 1 in 3,000, right? You can get this transient flare. And I think it's just really important for vets to understand that with this sort of product, you can get a flare reaction which is not related to infection. Now, because if you've got infection, that requires certain treatment and management, and it's important to do that. But that's iatrogenic, right? That's because something's gone wrong in the injection protocol. But if you get a flare with this product and it's not, you've ruled out sepsis, then you just need to be a bit more conservative how you manage that. And what I've seen, and I think, Leigh, to the one case in your project there that ended up with a severe adverse event, it was just sort of mismanaged, wasn't it? That the vets treated it as infection, which I understand, and it just sort of kept winding up that immune response in the joint. But I think the ones that we deal with now, we're very conservative with them, hit them hard with anti-inflammatories, even injected triamcinolone into there to calm. We did that once to calm one down, and so you get this non-septic inflammatory response.
Do you
Yeah, and I'd
find
say that,
Yeah.
ice, compression, systemic phenylbutazone, paracetamol as well often helps, and even sometimes a dexamethasone IVRP, just to help reduce, the immune system's just slight overreaction to the product, and that tends to go pretty well.
And sort of having that
Yeah.
conversation with clients, isn't it, to warn them that it can happen, but it's incredibly rare. I mean, you look at the literature, sort of flare rates or infection rates from other intra-articular medications are sort of closer to 1 in 1,000, whereas the rates with this is, like I say, less than 1 in 3,000. And I think just people understanding that you can, you just treat them conservatively, and they tend to resolve. But even if And again, I think some of the urban myths out there around sepsis, oh, if you get infection with this product, you'll never get rid of it. Well, that's just not true either. The gel is fully permeable to organic molecules. It doesn't interfere with antibiotic penetration. It doesn't interfere with, well, it doesn't harbor bacteria. It doesn't act as a nidus. It doesn't hide them or anything. Your synovial membrane's much better at doing that than the gel is. So it doesn't alter treatment outcomes or even future interventions, right? Even in human medicine, we were looking at some data recently, that patients have had knee replacement surgery and they're now using the arthrosamid to treat the post-operative synovitis, because it's just so effective at targeting that structure.
I have one more question in regard to this study that I think comes up frequently enough to where it's, kind of goes back to a previous question I asked, but kind of when it comes to this particular study, some veterinarians have raised some concern about permanent integration of the 2.5% polyacrylamide into the synovium, fearing long-term negative effects on the joint due to instability to breakdown. Could you comment on this and explain why the product stability is crucial for bioscaffolding as observed by the electron microscopy findings in the study?
Yeah, sure. Look, it's interesting that, because I talk to human orthopedic surgeons, and it is the one thing that they love about this product, that it does not break down and does not migrate. You don't want this stuff moving around the body, because you want it, and they look at it as a synovial implant, right? It's an implant into there. We know where it's sitting. We know where it's doing its job. And we don't want it, like I say, taking off or breaking down. It won't break down into acrylamides. Again, it's not how the polyacrylamide hydrogel works. But I think, stability is absolutely critical, and again, gives you that long-term benefit. It's not saying you never need to repeat a dose, because as we were talking about before, the disease might progress, or you get injury somewhere else, which you can repeat the dose on. But again, have I sort of answered that? Is that sort of...
Yeah, you have. So another study that is exciting for us that we'd like to share is the European study. I know that recently came out with some work that Dr. Mark Cooner has done with some fellow colleagues. And so I'd just be interested if you could share some of those insights in addition to what you've already shared from the Australia-New Zealand study.
Yeah,
Yeah,
Jason.
so I'll mention a
Sorry,
little
Dan,
bit about. Go ahead.
Sorry, I just want to say on that histology study too, Meg, the important thing for people to understand around that is the statistical analysis on the hyperplasia. It never goes beyond normal laboratory limits, so it's not something to be concerned about. So I know sometimes people misinterpret that comment in that paper, but you need to read into it to understand it. So sorry to jump in.
No, I think that's a good comment. I think that the term villus hyperplasia gets too much play here, and a misunderstanding contributes to probably what we quote fake news or whatever, because it truly, you start to look at villus hyperplasia in other locations within the body when it's going through a healing phase, whether it's implants for hips or knees, or screws across stifles due to subchondral cystic lesions, or even a bone break, fracture. It just, we don't term it that as often. It's just for whatever reason, it's people need to understand that it's just like you've mentioned before. It's 2.5% gel, 97.5% water, very small amount of the molecule in there, and contributing to increased cells is a better way to describe it, which is better. I mean, ultimately, we start to look at the synovial membrane. You get, better infiltration of your vessels, diffusion of nutrients across the membrane, so you can actively, promote a healthier synovium. The synoviocytes stay healthier, can do their job a little bit better. The whole gamut. I often term that whole process regenerative inflammation. And then I think that's what a lot of people have called it, that regenerative inflammation, because it's a good thing. And I think people need to realize whether you're talking about neutrophils or macrophages or any of this stuff that's going on with the innate immune system, there's a catabolic and an anabolic criteria within those cells. So you have an M1, M2 macrophage, just like you have an N1, N2 neutrophil. And they do things that help. You have to have a stimulate a little bit of inflammation to actually progress to an M2 macrophage. So you actually release a lot of the anti-inflammatory, downregulated, factors, I guess, within that synovial space. So
Yeah,
sorry to get on the
really,
soapbox there, but I think it's a whole part of that process.
I agree. Part of the body's natural immune response, right? It's actually how we heal stuff. And you want the body, the cells to come in and do things because what else, how else are you going to heal? And interesting, isn't it,
Exactly.
where human medicine's gone with, yeah, they're pulling back on anti-inflammatories and stuff because they've well recognized you sprain your ankle, you don't take an ibuprofen anymore. Put some rest it and ice it, but then get moving on it because there's, like you say, a bit of good inflammation there, a bit of regenerative inflammation that improves the outcomes.
Sure. So Meg mentioned this retrospective study. This was actually done and not by myself, but Dr. Mark Kuhner over there in Germany, and he has a sport horse practice, very esteemed practice with and works on the German Olympic horses, and they looked at over the last 10 years of using Arthrimid, the gel, 1,000+ horses. 80% again are warm blood sport horses, and then 20% are other breeds. Mixed, sex group, so geldings and mares primarily. And then the average age, which was interesting to me. So this is probably, I would term a little bit of an older horse study, if you will, because I think Jason, myself, and Leigh kind of work on younger horses primarily, or in the past at least. So 11 was that average age. And you can see that most of the group, the 83%, were sport horses. And this was to evaluate the basic safety of the product and to see what was the underlying disease, which joints were treated. And it's interesting too, because in a sport horse, you would expect to have an increase in age, that 10 to 12-year-old horse. And the top five joints, starting with coffin joints. And I think that we see that at least in the barrel horse side of things, because they don't make their starts typically until about 5 years of age. I see a lot of coffins being the top in the top five, and then fetlocks, pastern, stifle, and other joints. And so underlying disease, I think, is understanding that synovitis is the top, so they're getting ahead of the disease process earlier. And OA, 129 horses, and then you had different variations of types of OA and sclerosis, arthritis, and things. So average AEP score prior to injection, so they used the AEP scoring criteria, was a grade 1.5, which I think is probably typical among sport horses or even the Western performance horse, to say. Average increase to 1.5 or 1.45 when they flex the horse at a trot. And then they looked at medications and kind of specific treatments over the span of that horse, his life. So that's just the baseline of the demographics. And I think the important thing here to understand is that within that population of horses, 1,000 horses, they had very, very few adverse events. And so being that this is a long-term safety kind of review of different horse populations that have been using the product for quite some time, and you have 1,000 horses, similar to the 703 that Leigh and Jason looked at, you've got a really low 0.3% adverse event group. And a couple of those, one was post-surgery OA issue on a P2, I think that was a subchondral lesion. And then one was a bursa flare, and Dr. Cooner typically uses some intraepicane when he's doing some of his injections, and so that one didn't receive it. And then a TMT flare as well. So pretty low percent, and I think that's even lower than what I would have expected. So really, really good data. And one thing I wanted to mention is the long-term, safety of the product. It kind of speaks for itself to some degree. If you go back to that initial timeline, I was thinking of, it's 20 plus years of safe, use, whether it was humans, horses, goats, rabbits, across the animal species. And there's just lots of doses have gone into all sorts of mammals, and a very, very safe medication or therapy option. So anything specific, Mag, you want to talk about with
I
this stuff?
think when we look at these, because they're two dynamic studies, specifically, between looking at the racing industry that we saw with Jason and then looking at the sport horse industry. But all in all, I would think that what we're seeing is pretty, you know, similar as far as results are concerned. And what we're seeing is that long-term safety and what's happening with these horses. And then, the number of treated joints and what's happening, and looking at, to your point, that safety aspect. And so, I think being able to see these number of horses that are receiving this product at this point, would you agree that, would you have a hesitation, in any, specific, discipline or something like that would lead you to not choose ArthroMed, as far as something is concerned? Because based on this information, overall, I think it speaks volumes for itself, but I just wanted to see if there's anything that either of you would comment in regard to that.
I've used it in the Western Performance Horse, Quarter Horse Racehorse, Thoroughbred Racehorse, and been really, excited. And obviously Mark's done a lot with sport horses, and have other, colleagues that have done a lot with sport horses. So, very confident in the product. I think just looking at these studies, all of the studies that have been done through the years, under Contura's, direction, and outside too as well. I think it's pretty remarkable to see the safety data, and just the safety profile of the product itself. And so, yeah, one thing I did mention in this study particularly is, they did look at not just safety and the AAP scoring and all this. They also looked at, owner satisfaction and an owner survey. And I didn't include all of that because it was still getting organized. But, owner satisfaction is very high with this product, primarily because of that long-term efficacy, and so that's a big thing. And I also think that it contributes to, they feel like it's safe. And it's been proven time and again. And like Jason, to get his product, to get it approved down in as a market authorization, folks in Australia and New Zealand, you had to prove that safety data. And so it's, that's part of it. So
Yeah, I 100% agree. And to me, there's absolutely zero safety concerns with the product. I wouldn't put my name to it. I didn't become a veterinarian and spend 30 years in clinical practice if I thought it wasn't safe. I'll put this into my kids' horses. I wouldn't do that if I didn't think it was safe. And you talk about owner satisfaction, your wife and your kids are your biggest critics, right?
absolutely.
And I think, like you say, Jed, it just astounds me the multi-species safety data. I think we've got two really important pieces of work, which is great to be able to bring out. But as far as repeated dose over a long time, these back up the like I say, the what we know about the chemistry and toxicology. This now backs it up from a clinical perspective. These two pieces of work, so we'll push on and get these published. But you also look at the human work, over 20,000 human joints injected now. You look at probably close to 1 million women have had this injected for the urethra for stress-induced urinary incontinence. It's now the treatment of choice in the US for that disorder, and getting away from the mesh controversy and that they had. So again, yeah, it's so many hundreds of thousands of doses with zero safety concerns. So just think vets shouldn't worry about it. Obviously, you've got to be careful on your injection technique, as with any intra-articular treatment. And accuracy of diagnosis, I still come back to, we see really good results with this product when you pick the right cases and manage them the right way. And 80% efficacy is, again, across multiple disciplines, multiple joints. It's pretty impressive.
So one of the things that leads us sort of to this next study that we're talking about is when using Arthromed, one of the most common questions that comes up with veterinarians is, can it be used concurrently with other intra-articular therapies? And so that was really the question that really, I feel like, ignited this particular study, was because one of the most common questions we were getting is, can it be utilized concurrently with a steroid? And so JD, would you mind going through and kind of talking about this particular study?
Sure. I think it like some of these other questions, we get asked about it all the time. Can we put it with not just steroid? In this case, we're going to talk about betamethasone, but triamcinolone, depomedrol, or methylprednisolone, or even any of the biologics for that matter. So IRAP or PRP or Prostride or any of those things. And I think the important thing here is we wanted to evaluate, because this is probably the number one question, or at least one of them in the top 5 for sure, maybe top 3. What happens if we use it with a steroid? What is it from a safety perspective? What does that look like? We didn't look like it at it necessarily from efficacy. We assume that, but in this case, there was a 10-horse study that was done by Dr. Whitaker, where he used betamethasone in these horses, 6 milligrams per ml, along with 2.5% iPAAG, the 1 ml injection. And he didn't have any adverse events in this 10-horse study. And these were all normal joints. They looked at joint effusion and circumference throughout the study, day 0, 1, 2, 3, 7, 14, and 30. And then also evaluated what the caretakers' observations were. So the people that were overseeing these horses. And what did they see? Did they see anything at all? But in general, there was no adverse events, and so it was proved as well tolerated and safe, and felt like that was important for the industry to have that information. Not that we encourage the use of it. I think that's where sometimes that gets misconstrued. We're not doing this to say we recommend you using it together with Arthromed. No, that's not the point. The point is that if you want to, or if there's a reason to in a certain case, it's safe. And I think that's a very different than just, promoting it or recommending it. Because for me, at least in my experience with the product and just how I treat cases, I don't just blankly say, I'm going to just put steroids with Arthromed. No, I typically am using Arthromed singularly most of the time. Occasionally with an orthobiologic, or occasionally if with the steroid, but it's, I would say 70+% of the time or more, it's probably singularly with just Arthromed.
Jason,
Yeah,
what's been your clinical experience? I think, utilizing Arthromed and steroids. I know some of the things that you and I have talked about in the past have been looking at that amount of effusion within the joint. Can you share sort of your experience with that as well?
Yeah, for sure. I mean, like you say, JD, it's sort of, to me, it's counterintuitive to use the two at the same time. But I get the pressure vets come under, and I think it's a really cool little study to look at from a safety aspect, and it's what we would have expected, right? And I think there's some people going to look at excretion rates again on sort of Arthromed augmented joints as well, because I think Though saying that again, we've been using the product for years in Australia and had zero issues with detection times on corticosteroids as in arthroid augmented joints. So I don't think there's any issues there. And in fact, it probably increases excretion time because it does improve the vascularity and cellular activity in the region. I guess where we got to, Meg, is that we start with arthroid. If we've got a lame horse off the track with a severe acute synovitis, we might still use steroids first. Or if we've got that time pressure that a big event's coming up, it's coming into a race, and we just don't have that sort of 2 to 4 weeks that we need with the arthroid to get it right, then we might put some steroids in. But like I say, our trainers have just become so attuned to the product that they'll get arthroid in early in the prep, and then if the horse still develops some synovitis, through the racing calendar, then we'd use an orthobiologic or we'd use some steroids. And what we find is we actually just get much better responses, and we're using lower doses. So again, probably using 5 milligrams of triamcinolone instead of a normal 10 milligram dose, and seeing just as good a clinical effect. And I think when you start to look at the science behind that too, right, that lower dose corticosteroids is better long term for the horse because you're not getting that suppression of cartilage, gene expression, and things like that, which we know with high doses of corticosteroids, you eventually get to that stage and end up with an arthropathy.
Do you find when you use combination versus separation, when you're looking at combination, one of the questions I often get asked is, talking about the timing, if you will, and, what does that look like, in between, treatments and doses and that kind of thing. So I'm just curious for both you and JD, if you would sort of share your clinical experience and what you've seen, and talk with other veterinarians around the world and sort of how they're incorporating, sort of looking at that time interval if you're going to use things in common, even if it's not concurrently, but if they're going to use it in combination, what seems to be levels of success?
Yeah, I think there's no right or wrong. I just know from my point of view, as a bit of a purist, I guess I always gave a 2 week window. Just I know that the gel takes 10 to 14 days to integrate, and I know that the cortisone's probably got some clinical, it's suppressing that inflammatory response for 7 to 10 days. I get longer in some cases, but also shorter in some cases. So I always just left a 2 week window. I know Leigh uses it a little bit differently, and he might get that a little bit closer together. What do you do, JD?
Yeah, so I mean, it's so case dependent, I guess, for me. But I've become a purist on it for the most part. I don't typically combine. I have, but not typically. But if I have a case come in, and again, I think it just is joint dependent, horse dependent. But for instance, kind of what brought me to the whole picture of using Arthromed pretty regularly was the stifle case, and it had some changes on a meniscus, along with synovitis and some other issues. And so it was pretty effusive at the time, and I actually wanted to get something in there to bring down the effusion, and I ended up IRAPing the horse first a couple times. And that was about a 2 week period. And I came back in and then I put Arthromed in next. But it wasn't, yes, it was within a 30-day window, but it sure wasn't at the same days or at the same time I wrapped the horse. But I've also gone in and had situations where even it's been a little effusive, but it's been some time. I've noticed the fusion. Maybe the horse didn't respond to steroids and HA, years ago or something like that, and it's come back, and I think it's time to, go the Arthromed route. The other situations that I can think of here where I typically am a big time purist is we see a lot of metabolic, insulin dysregulated horses on the Western performance side, especially this time of year with the green grass coming up in the springtime. And, even my wife's, who's a trainer, even when our horses, we have to pull off of pasture this time of year. And so that's one that just got injected and got Arthromed, alone. And there's good reason not to use a steroid in that situation. And I just go, and I don't even put in PRP or ProStride or any of those other things. So, but that's kind of my route.
Yeah, that's a really good point. Actually, we see a lot of that in Australia, that insulin dysregulation as well. And I agree, it's just been a game changer for those sort of show hunter classes and stuff. Because you can just use this product. It's really safe. Why would you use steroids? And I guess the challenge for us as vets in the veterinary industry, right? And we know the pressure you sort of mentioned before, JD, about HISA and racing in America, and that social license has been challenged all over the world. And I just think this product, it just offers a whole new tool in our bag. And once you get your head around it, I would start to question why you're using steroids. I think they've got their place. Don't get me wrong. I think they're an amazing drug. They're very potent. But like you say, you've got to think about why you're using them. And like you say, JD, a case by case basis. And I think it's interesting hearing, because Lisa Fortier at her talk at AAEP in the Moon lecture sort of talked quite similarly, right, about combining the use of Arthromed with orthobiologics. And I think it just makes so much sense as to, what are we actually trying to do? And once you get your head around what's happening inside the joint, what are we trying to do with our treatment and management of that horse? It just sort of gives us such a cool opportunity to change the outcomes, I think. Whereas before we're just so focused on let's just dull the inflammation. Let's put some cortisone in and try and suppress the inflammatory response, but we weren't doing anything else really for that joint. So.
Yeah, no, I 100% agree. I mean, it makes sense to allow the body to start to heal itself and, produce some anabolic reactivity of some sort. And we've been trying to get that done for a long time, and steroids don't really help with that. They just reduce all inflammation and cut down on everything, all the cytokines and proteins and those kind of things. But one thing I think was also important on that timeline is we start to go back and look at the reasoning why we started using it, or at least looking at the polyacrylamides in the worst case scenarios, and then kind of moved on to more typical OA or synovitis or capsulitis cases, more near term, earlier in the disease process. I think it just has to do with our understanding of what's actually going on in the joint itself too. We've so long focused so much on the cartilage as the main, instigator of all activity and problems within the joint. Don't get me wrong, it does have problems, and there's plenty of arthritic, issues within the cartilage, but the synovium is sort of the a lot of times left out here in left field. And I think that we've kind of come around and realized that, maybe it's a synovium dummy. Start looking there for the disease. And, if you don't have a healthy synovium, you really aren't going to have a healthy joint to begin with. And you can't really begin to help, stop the deterioration of the joint and the progression of OA if you don't start with the synovium and a healthy synovium. So I think looking at that 20-year life cycle was, to me, was reflective on, okay, I was focused in on cartilage. I was focused in on what do I see radiographically speaking, or even, back then. And if I didn't see it there, then I was probably, it's still there. I just didn't realize that maybe I was looking in the wrong place or thinking about the wrong thing. And I think it's now that I do realize that the synovium is such an important part of the health of the joint. I think it's been a game changer, and Arthromet's addressed that, and I think that's what makes, has helped so many horses and ultimately vets and trainers and owners and all of that. So
Yeah.
But I think that's really, where I'd love to for us to kind of switch gears a little bit and kind of really talk about sort of these practicalities when it comes to diagnosing these horses. I know that's one of the keys to success that we have all three of us can say that we've seen. But what are some crucial points when it comes to proper diagnosis that you think that we as practitioners really are essential to consider in order for us to achieve success with Arthromed?
I come back to intra-articular analgesia, and I think in a coffin joint that can be difficult, right? We all understand that, that's going to diffuse out and block out everything, but I still think it's interesting when you look at those figures from Mark Cooner study there, and high number of coffin joints and still good clinical efficacy, and they have good farriers in Europe, and we lack good farriers in some parts of the world, but. To me, if I was just talking specifically to racehorses, we very commonly have knee and fetlock issues. If it flexes to the knee, I think a passive flexion is incredibly valuable to me when I'm doing a clinical examination. And I keep coming back to, as a vet, your eyes and your ears and your hands are your best diagnostic tools. I'll always flex those legs, say passive flexion. Yeah, I'll do a flexion test and trot them up, but that's often not that indicative for me. But I'll really dig into those joints and say, hey, is there a bit of bone pain going on? Just how sore are they? And then I'll block them out, and I do like to block them out. And I like sort of Mark's comment again there about the intraepicane, and I know he's been using that quite a bit up there. And obviously X-ray them, but you got to X-ray them. You got to have a look. Yeah, you can get a sagittal fracture. You can get a small condylar fracture. We all know the insensitivity of X-rays as well. So we do a lot of scintigraphy as well. But to me, if it flexes up and it blocks to the joint, I know it's going to be a good Arthromed candidate. And that's in knees and fetlocks. And I don't know, JD, you're probably better to talk to coffin joints and stifle joints because you deal with a lot more of those than I do. So.
Yeah. I would say that similarly, it's to me, if it's going to flex, distal limb flexion is kind of plus or minus, in the Western performance world on the, if we're doing with the forelimbs, you kind of, okay, it could be anywhere on a barrel horse. Let's just say it's on the forelimbs. They're like a racehorse, so it could be a fetlock, it could be a knee, or it could even be a coffin. But I like the blocking, part of that. Yes, flexion, put your hands on the horse, palpation, all of those things, and then being able to block out, a joint if possible. I think, and if it does block to that joint, I typically have pretty resounding success with Arthromed in those cases, usually. And so I like that. I mean, stifles 100%. There's most of the pathology we see is in the medial femoral pouch. And so if I block the stifle and it blocks out, and I'll put an ultrasound on always and go in there and take a look, X-ray, and I'm pretty confident that I'm going to stick Arthromed in there and a couple mils, if not more. I'm going to have some success there. And then the one question that always pops up is that do you wait, or do you just go ahead and stick it? So you block the stifle joint. Do you wait, or do you go ahead and this kind of goes to the safety part, or do you just stick it in? And I used to be on the wait a couple of days, or wait at 24 hours camp and then stick it in the next day. But now, after kind of hearing Dr. Cooner speak and other folks, I really feel like, and I just go ahead and put it in the same time frame, so the same day. I think it actually I have no problems, and typically those flare less and seem to do a little bit better in some situations, or at least in my case. But the other thing is I'll mention hawks, and we, I put it in hawks, and I remember Mark and I talked about this in Denmark. He's just like, it's just crazy that, that's such a low motion joint. But I think it's low motion to us, but it's such an integral joint in the Western performance world of how much they're on their hind limbs and what they have to do in their activity. And so I think that matters a lot. And so that synovium probably does get pretty inflamed there, but it has some high success rates and even hawk joints, even though that's a low motion joint. So I'll just kind of mention that too.
Yeah, we find that, we find really good response in hop joints as well. And
Yeah.
like you say, some people say, oh, it doesn't sort of fit with the mechanical mode of action, but I agree. I think it does. I think it treats synovitis, and those joints they're tight, they're low motion, and sometimes you stick a needle in there and you get fluid jumps about 6 meters across the barn, and you go, that was a pretty inflamed joint. So
Yeah.
I don't know, the sort of putting your finger into the hop joints and that. I've never believed that I've really noticed much difference. And a vet once told me, if you want to get a difference with that test, you should just grow a really long thumbnail. And I thought that probably made sense to me. So, but I think with hawks, I tend to do diagnosis by treatment because, again, I think radiographs are so insensitive on hawks. You see some horrendous looking hawks and the horses are jumping 1.50 m, and you see hawks that look perfectly normal and you treat them and the horses, go really well. So, but I was going to ask you, JD, with stifles, do you ever just go off ultrasounds and just put that on and look for some synovitis and go, yep, that's where there's an issue? Or
Yeah, that's a good question. I know with Cooper Williams, Dr. Williams, he'd probably say, yeah, absolutely, 100%. I'll still will X-ray. I'll just do typically a AP view, and it won't do the obliques and the laterals. But I always use my ultrasound. So I feel a lot more confident in my ability to see what's going on with the cartilage, what's going on with the meniscus, the ligaments, meniscal ligaments and whatnot. I can look at the lateral pouch as well, lateral meniscus, evaluate a lot more of the stifle joint itself. And honestly, at least in our neck of the woods and with some of the barrel horses, and I think it's probably a little bit of breed specific, we get some lateral, pathology too. So it a little bit more commonly. I know there's probably not a ton of research out there, but um, just kind of anecdotally speaking from my colleagues that treat a lot of barrel horses and some of the Western quarter horse race horses, we see some of that as well. So.
yeah. But I think it brings up a good point, Meg, that sort of, because this product works so locally, and as we know, if you put cortisone into a stifle joint and it diffuses around and it sort of probably heads off to the different areas and it gives you a nice systemic effect, you sort of get away with a lot. Whereas I think if you have a disappointing outcome with arthrimid, you do got to just go back and think about what's going on. Were you accurate with your injection placement? Are you sure about your diagnosis? What other pathologies going on? Because it's very, very targeted into the synovium and into the joint. And like I say, I think that's where coffin joints. But how do you manage your coffin joints, JD? Because typically I would still, talking more about performance horses, I guess I'd still start with corrective shoeing, even just shove them on some systemic bute for a week or something and just let everything calm down. And I probably wouldn't go into that joint for at least a couple of shoe cycles, to be honest.
Yeah, I think we can get a little aggressive sometimes and just jumping into a coffin joint. That seems to be the more one that sparks a little bit of a flare or transient reaction, so to speak. I'm probably a little different in this case. A lot of times in my coffin joints, I'll eye wrap them or PRP them for a week. It just gets some inflammation, to decrease. and then I'll typically go back in with Arthromed. At least that's what I've been doing over the last, year and a half or so. Even, but I've always, yeah, I still have always really liked IREP and the coffin joint for whatever reason, and so I do a lot of IREP there and a lot of Arthromed and coffins, and like you, I think the shoeing issue is super important. And if that can be the most challenging when I'm dealing with the racehorse clients, it's definitely a lot worse on our side. It's just, low, the hoof pastern axis, low hoof angles, all of those things tend to be just biomechanically off. And you start to get that improved, and boy, you can just tell that hoof walls it's not hot. It's, the fusion starts to decrease. I mean, it kind of naturally occurs even without any therapy at all. But yeah, like you said, starting there is a big part of it.
Yeah, it's under even with so that palmar angle and plantar angle, because even with my hock horses now, if
Yeah.
I'm X-raying hocks, I'll just take a lateral of both hind feet, and it's amazing how oftentimes you'll just see that they drop behind, and that's loading up through that suspensory and hock area, and again you just sit them up, and again I think if you're not getting a response to, because again, blocking out a hock can be, it takes out the top of the suspensory too, right? So, and I think
Yeah.
sometimes differentiating those two areas of pathology can be really hard. And I think that's where, as a vet, I think I learned to sort of talk to owners about managing stuff. Yeah, I can spend $2,000 or $3,000 of your money, and we can do a scintigraphy, and we can do a full lameness workup and nerve blocks and send it through MRI, et cetera, et cetera. But hey, maybe we just treat this and come back in a month and see what's happened, and we'll, because if it's not this, it's probably this, and we can try something else. So, and sometimes that's more cost
Yeah.
effective. Um,
I think we're always trying, as vets, we're curious, and we're always trying to get to that answer, and we want to have prove to ourselves and them that we can just get that answer versus maybe trying to work through it diagnostically through a therapeutic option. And in this case, the hawk is the prime joint to do that. Your diagnostic therapy
Yeah.
of choice, and Arthromed is I've had a lot of success.
Yeah. And I think, Meg, I don't know, I'm sort of preempting your next question, but I think that the post-operative management or post-treatment management is I definitely just sort of back off these horses now, if I'm using Arthromed, and I'll put them on what I call sort of 2 weeks of easy work or half three-quarter pace with the racing horses. We'll put them on the treadmill, we'll swim them, we'll walk them, we keep them moving, because I'm a massive believer in horses have got to be exercising, it's got to be moving. It's got arthritis. The last thing you want to do is rest that horse and lock it up. But again, I just find backing off them a little bit will just seems to give a better response for longer. And I think it just makes sense again when you dig into that histology paper that we've discussed, that you've got this low-grade inflammatory response as the gel's getting integrated into the synovium, and just give it a chance to do that.
So speaking of clients, we kind of touched on this a little bit, but I think, as we try to manage and we try to change some mindsets on what has historically been done, I think it really is thinking through some of the managing these practices that we've done for quite some time. And, how do you convince trainers and owners to really move away from what we consider to be routine joint injections? And so just coming back every 6 months and, injecting their hocks, injecting their stifles, and really getting them educated on, what the best medicine is, and really, why do we need to come back and see these horses and reevaluate and do more of these, what I consider to be, certainly in my clinical practice and what I've done, even with my daughter's own horses and things like that, is just like managing them differently just because of the benefits and longevity of Arthromed. But what are some keys and pearls of wisdom that you have found for each of you in your experience and, talking with clients about sort of changing that mindset and overcoming some of their, thoughts and beliefs?
My pearl of wisdom is choose who you want your clients to be. Because the good to me, the best people I've worked with care about their horses and they get the best out of their horses. Now, we all know there's trainers and stuff out there that don't do that. It's a numbers game and they go hard and it's sort of a attrition. But that's not how I sort of operate. And so lean into the trainers that think like you think. And it probably took us 2 or 3 years in Australia, but literally, I'm pretty excited now when I go to Melbourne and talk to guys and they say we've changed how we train horses, and the likes of the racing association there that started off as a bit of a cynic, healthy cynicism. I'm all for that. But now they're sort of raving fans of our product because we're not saying inject these horses and gallop them. We're saying inject these horses, give them a chance to work. If you've got an accurate diagnosis, they'll respond. If they don't respond, reassess your diagnosis because you've got to start thinking about subchondral bone disease. You've got to start thinking about hairline fractures, things like that. And as to the work Leigh's showed us before, with no catastrophic injuries out of 17,000 races. It's very, very powerful data to me. So I think we just got to keep leaning into that, right? And it's probably an industry wide. It's good veterinary medicine, good vet practice. The trainers leaning into it and understanding that they need to think this way. And like I say, I think this product gives us another tool in our bag that allows us to achieve that, whereas we didn't before because it was sort of cortisone and hope. Now we've got something better.
For sure.
Yeah, I would agree. I think that the routine maintenance injections ship has sailed, and you probably don't want to be on that ship or that train or whatever, so to speak. I think it's, there's plenty of vets probably that are out there that have made a living doing it, and and I'm not saying that anybody was doing anything wrong. I think it just is what we had in our toolbox then, but now we have different tools, so we can do a little bit better medicine and manage cases a little bit differently. Not to say that there's not the occasion where you're working a show or something and you're trying to get the horse to finish the competition over the course of the next week or whatever. But like you said, Jason, when you have the ability to work and train horses differently, to treat that horse with something that's going to affect the disease process and the synovium, and then go on and rest it and give it the appropriate time, that 2 to 4 week integration period of Arthromed, of the gel, I think it changes your whole outlook on treating this disease and training the horse, and you start to think about things differently. And I think that process takes some time. US is a little behind on it, but we're not too far behind. I think we're starting to catch up a little bit. So
well, thank you both for your insights and sharing everything tonight. We're pretty much our time is up now. I know we could keep all three of us. We're so passionate about the product and its longevity and its safety and everything that's been shared tonight. And really, let's be honest, it really is a game changer. And what we've all learned, I think, is in order for these horses to remain competitive and at top level, it really starts with a healthy synovium, and a healthy joint starts with a healthy synovium. So with that, I will turn it back over to Robin.
Thank you. I would like to thank Contura Vet for, again, allowing us to be a part of this. And thank you to all of our panelists and Dr. Green, our moderator. So thank you to everybody for joining us, and I hope everyone has a great evening.
Thank you.
Thank you.
thank you.
Have a good night.